Welcome to RSSDI TV 2020. I am Dr. Shahu Ingole and you are watching me on RSSDI TV 2020 brought to you by Wockhardt. Today I am honored to have with me an eminent personality and renowned senior endocrinologist from Srinagar, Dr. Abdul Hamid Zargar sir. Sir is the ex-director, Sher-e Kashmir Institute of Medical Sciences, Srinagar. Welcome to the show, sir.
Thank you so much.
So we all know that the DPP-4 inhibitors are one of the preferred class of oral hypoglycemic agents, and they have featured accordingly in all the major guidelines for the management of the diabetes. So, sir, we would like to know from you what is your opinion about the usage of various DPP-4 inhibitors in the clinical practice?
Dr. Shah, I'll tell you, gliptins have been in use for more than a decade. And prior to that, two main secretagogue agents were sulfonylureas and insulin itself. Ever since gliptins have come in, managing diabetes has become rather simple, at least in the initial stages or in those people where you need a hemoglobin A1C reduction of somewhere 0.7, 0.81. Now, over this 1 decade, what we have seen is that their efficacy is reasonable. In Indians, gliptins seem to be working a little bit better. Some people believe that it might be on an average causing a hemoglobin A1C reduction of up to 1.4 when the optimal dose is given. But on an average, most of the literature would say 0.8, 0.9 up to 1. But more than that, its safety profile is amazing. It's almost like a placebo. That is what its safety profile is. And it does not have many interactions with other drugs because, as you know, a diabetic patient, particularly patients with type 2 diabetes who are elderly, invariably have hypertension, have dyslipidemia, many have associated coronary artery disease, have some amount of renal dysfunction. So they are on a barrage of drugs, morning, evening, night. And the interactions with this class of drugs are very minimal. So that's why this class has been accepted well, and decades experience is a huge experience. And most of the clinicians are comfortable with this class of drugs in general.
Okay, sir. So, sir, if we consider various DPP-4 inhibitors, how do you see these DPP-4 inhibitors as far as their effect on the body weight and the risk of hypoglycemia is concerned?
You see, we have now various hypoglycemic agents available, and we have various gliptins available. Now, two important things for all gliptins, whether it is from vildagliptin, which needs to be given twice a day, or sitagliptin. In India, we use loads of tenaligliptin or sexagliptin, sitagliptin, the landmark gliptin. All of them, one important attribute that the magnitude of hypoglycemia is minimal. Because why it's very important? Because prior to this class of drugs, we were using sulfonylureas in a very big way. And starting from glibenclamide, then glipizide, and then gliclazide and glimepiride, we were quite petrified with the possibility of hypoglycemia, particularly in 80s when we used to use a lot of glibenclamide because that was the only sulfonylurea then available, and then glipizide came. So hypoglycemia profile is amazingly good. Many drugs, including insulin, which is the best thing to control diabetes ultimately. But sulfonylureas and insulins usually, when they control insulin, also have a tendency to make the patient put on few kilos. And in an obese patient, it doesn't go well with the patient, and it causes other issues. Because as I was telling you just now, that these people have more than one issue, particularly cardiac issues as well. So it is weight neutral. Most of them are weight neutral. And in fact, there might be, if you look in comparison to sulfonylureas, because most of the studies are in comparison with glimepiride, you will have, in fact, loss of a kilo or two, not adding a drug, not adding a kilo or two. So that is a huge advantage that we have with this class of drugs. So I would say this hypoglycemia and weight neutrality is something that again weighs in decision making when we prescribe this class of drug.
So, sir, we all know that the SGLT2 inhibitors and the GLP analogs, they have primary position as far as the management of the type 2 diabetes mellitus in patients with the cardiovascular diseases or renal diseases is concerned, as far as the various national and the international guidelines are concerned. So, how do you see the DPP4 inhibitors from the perspective of the cardiovascular safety?
You see, I'll tell you, you made a very apt statement. In the recent years, in the last half a decade, SGLT2 inhibitors, GLP-1 receptor agonists have picked up quite a bit, but predominantly in a section of a patient population. And amazing class of drugs as they are, but they are a prerogative of a relatively small segment of professionals who can practice them. Looking at possibility of euglycemic diabetic ketoacidosis, looking at possibility of peripheral vascular disease, looking at possibility of amputations, or and so looking at possibility of recurrent infection. So a good endocrinologist, diabetologist would know why to choose it. Gliptins, in comparison, have their own cardiovascular data. Sitagliptin is, TCOS study, we know, did not, it was cardiovascular neutral. Basically, examine trial, which was with alogliptin, and severtemy trials, which were with sexagliptin. They were also predominantly from 3-point MACE cardiovascular neutral, but there was a slight predisposition to hospitalization for heart failure, and which was quite a bit talked about in literature. But the same would not hold true for TCOS did not show the same thing for sitagliptin. Or we had Carmelina trial, with Carolina trial, two trials with linagliptin. It did not show any predilection for heart failure. So cardiovascular safety reasonable. Vildagliptin did not have a dedicated trial, but now we have more than 10 years experience with it, and smaller studies are about cardiovascular safety available. Tenaligliptin, again, we do not have a cardiovascular dedicated study, but now the mammoth amount of that we are using in India tells us that there hasn't been so far any major issues reported, even though some people were a bit concerned about QT interval prolongation. But the widespread use has not shown any post-marketing problems so far. So this is where we stand. I would, at best, cardiovascular neutrality, and obviously not the benefit that was shown with SGLT2 inhibitors or GLP-1 receptor agonists. Leader showed that, AMPERAG showed that, and down the line, many studies showed that.
Okay, sir. So specifically, sir, if we talk about the one DPP4 inhibitors, that is vildagliptin, which is going off pattern recently. So how do you see this molecule in the clinical practice?
I'll tell you now that, as I was telling you, we have had a huge experience with this drug, particularly in India. We have been using it for a long time, and we're very comfortable with it. I would say the only problem with it is that if you want to get an optimal hypoglycemic effect out of it, or best effect out of it, it needs to be given twice a day, because its duration of action is 8 to 12 hours in comparison to sitagliptin. But the advantage would be, now, as you very rightly said, now it has gone off the patent and a lot many people are coming up with this molecule. Affordability has increased. The cost has gone down. And our country, and particularly in the current times, economic stagnation, and COVID has also put the whole world on the back foot. So probably, it will be a boon if it's made cost effective. It is as costly as a sulfonylurea. As a clinician who has been in endocrine practice for last almost 4 decades, I would be delighted. I would say that it will be used in a very big way, because you don't need many issues to take into consideration while prescribing it. Cost is an important issue. Hypoglycemia an important issue. Availability not now an issue, because so many concerns are coming up with this thing. Distribution not an issue. So it seems to have a good future, at least in our country.
Okay. So thank you so much, sir, for joining us on RSSDI TV brought to you by Wockhardt, and thank you for sharing your views. Thank you so much.
Pleasure always. Thank you so much for calling me.